So coming to the ventilator-associated patients. Sorry. So ventilator-associated is ventilator-associated bundles or ventilator-associated pneumonia. The word itself explains that a patient on ventilator after 48 hours of intubation has developed temperature, has developed leukocytosis or reduced in counts, has developed increased secretions. There are X-ray infiltrates, there are increased secretions, and there is culture positivity. Then he is you term him as a ventilator associated pneumonia. What happens if he develops? As I told you, his length of stay increases, his the morbidity of the patient increases, the cost increases to all these cases. So what do you do? Prevention is always better than cure. So elevation of head end of the bed to between 30 and 45 degrees is a must. And I just crossed the second one. Can you all tell me what is it? Why I crossed the chlorhexidine and why I have shown a picture with a toothpaste and a brush. And the third thing is daily sedation vacation. That means whenever for agitation, whenever you start some sedation like a fentanyl or a propofol or benzodiazepines are generally routinely not used, you stop them in the morning and awaken the patient and assess whether he is weanable from the ventilator. Then deep vein thrombosis or prophylaxis, which should be started within 24 hours of start of mechanical ventilation. It can be a chemical prophylaxis like in a low molecular weight heparin or stockings, that is compressive devices, and peptic ulcer disease prophylaxis, which needs to be started within 24 hours of start of mechanical ventilation. And as I said, these are all device related, and you need to assess the readiness of these patients every day. Can I extubate the patient? Is the question you put to yourself every day. And these should be all nurse driven protocols wherein the nurse puts a tick for the all these, and she says and assesses whether the patient can be extubated or not. And these type of assessments have given better results in preventing ventilator associated pneumonias. Next. So this is, though this slide appears very clumsy, it is very important that I say, okay, don't use chlorhexidine, use toothbrush. I say avoid benzodiazepine. So there are proven or certain things which are very important, that is in essential practice, which have shown good evidence, is avoid intubation, not in all the patients, but in avoid intubations where you can prevent intubations, like a COPD, like a pulmonary edema, like an immunocompromised host, where you can use NIV or a high flow nasal oxygen. Then minimize the sedation. Don't over sedate or continue sedation for a very long period, and maintain and improve physical condition, nutrition, head and elevation, and provide oral care with toothbrush, but not without. Till the latest guidelines said it is chlorhexidine. Now they changed it to toothbrush, and provide early, start the feeds very early, and change the ventilatory circuits only when they are contaminated. So the other additional approaches are these of them, only the first one, and the change of ventilatory circuits and providing early nutrition are important, and they are of very good evidence. And the other approaches are wherein selective oral or digestive decontamination, wherein the ICUs are where there is low prevalence of antibiotic resistance. You can go with this method and utilize endotracheal tubes with subglottic suction. We do use in our ICUs. It is good. And when you're anticipating long ventilation, that is more than 48 hours, because these tubes are little expensive than the normal ET tubes, and consider early tracheostomy when you are anticipating that the patient will be on prolonged ventilation, whereas in certain neuro cases, you can go for early tracheostomy, which has shown benefit in terms of weaning the patient from ventilator. And the feeds, there is no need to aspirate the Ryle's tube each time you give the feeds. You need to check the position, but there is no need to aspirate the Ryle's tube. And generally not recommended are oral care, probiotics, and tapered endotracheal tube cuffs, and automated control of endotracheal tube cuffs or cuff measurement, or all the other prone positioning, chlorhexidine mouthwash, stress ulcer prophylaxis, and monitoring residual gastric volume, as I said. So coming to the gist of this, go for NIV or high flow oxygen whenever feasible or whenever recommended. Sedation holidays, 30 degrees or to 45 degrees head and elevation, brushing the patient, planning to extubate whenever is weanable and meeting the criteria for extubation are very important in preventing VAP. Next. Hope you're all understanding. Anything, you can just go on the chat box. Anything, Lavanya, in the chat box? Lavanya?
A few questions, ma'am, which we discuss at the end of the session.
Okay, fine. So, risk factors. So, again, VAP is early VAP and late VAP. Early VAP is less than 4 days, and the organisms in early VAP are antibiotic susceptible, whereas late VAP are caused by drug-resistant bugs, and the risk factor for antibacterial, antimicrobial resistance in VAP is prior if the patient is already exposed to antibiotics within the last 90 days, patient is in septic shock and ARDS preceding VAP, and more than 5 days of hospitalization prior to occurrence of VAP. That is, he is already on ventilator for more than 4 days, and the other associated systemic illnesses or multi-organ failure is there. So you go for empirical antibiotic, you send for cultures. I told you the CPIS criteria, wherein you see for tracheal secretions, you see for new onset infiltrates, you see for the rise in counts, the rise in temperature, and any increase in the respiratory parameters, P by F ratios, and you also check with the cultures. And you either, if you're suspecting Pseudomonas aeruginosa, beta-lactam based antibiotics like piperacillin tazobactam, you can go for, or if is already you're suspecting BLI resistance, then you can go for meropenem, and the methicillin MRSA coverage, you can go for vancomycin or linezolid. So this is how I told the VAP, how to prevent VAP, what is VAP, and how do you assess that the patient is in VAP, and how you're going to anticipate that, how you're going to differentiate early and late VAP, depending on the duration, depending upon the severity, depending on the P by F ratios. Late VAP is always, the P by Fs are less, the antibiotic resistance is more in late VAP, and you're going to, how you're going to prevent VAP is what we discussed. Hope it is clear. Next. So coming to CAUTI, CAUTI is catheter-associated urinary tract infections. So when you are inserting, you have to follow the protocols of the institute. You have to utilize alternatives like toileting regimens or male cath or the condom caths, and evidence-based care practices and product selections, like you have to go for a select sterile insertion technique, routine metal care, prevent urinary reflexes, maintain closed system. The system there should not be open at any point. And you have to go for a smaller size catheter, and you have to place it at properly above the thigh, and always the system should be below. And The removal, reminders and stop orders. Again, the nurse has to follow. They should have a specific protocol, or every day you need to document the necessity for continuation of Foley's. And as I said, nurse-driven protocols are very good and they have proven of much benefit. And you have to, whenever there is a CAUTI, an incidence or the CAUTI number of CAUTIs in the ICUs are assessed, or they are compared with the benchmarks in the institute or the other institutes, and you go for the audit where the where is the preventable step, at what point you can prevent, and you can get a feedback, and you can again go for the education and surveillance of these cases. And this system, the entire system, that is how you take precautions in every step, the insertion, the continuity, and the minimize the duration, and educate the staff and surveillance. Next. So no CAUTI, need for catheter assist, refer to indications, scan bladder, considered alternatives, and document reason. Is there a need for the Foley's in this case? Is there a bladder retention, bladder distension, or neurologically unfit, or he can't void urine? Is your question, and you need to document that and obtain patient consent and patient education competency. All should know how to insert a catheter, how an asepsis should be maintained, and there should not be any obstruction to the flow of the catheter, and timely catheter removal is important. And infection risk, collect specimens only when it is clinically indicated. You remove the bag and you collect it from there for any cultures or any CUE or complete urine examination.